And okay, and welcome to the Davies Use Case webinar being presented by VCU Health on teletracking. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety at HIMSS, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information technology-enabled care delivery. So it's my pleasure to welcome our speakers for today, Lynn Goodlow, Sharon Badnar, Dr. Georgia McIntosh, and Cynthia Matthews. I would turn the presentation over to you, and you all can begin when you are ready.
Good morning. Thank you so much for having us here and being willing to listen to our story. I want to begin to tell you about the roadmap that we used in our organization to accomplish this work. Let me tell you about Vision by Design, and specifically the Throughput and Capacity team. What you see before you is a roadmap that guided our group to improve the care that we provide to patients, to the families, and the community that we serve. VCU Health is an academic medical center with hundreds of years of history of serving the population surrounding our hospital. We've always had three missions in mind: patient care, education, and research, so that we can not only provide exceptional care today, but also guide the care for tomorrow. We knew to be doing the best for our community that we need to assure that we can always keep our doors open. Our organization also knew that healthcare was continuing to change, and that if we did not change, each of those missions could be impacted. If you look in the top purple box, what you'll see are those missions: education, research, and innovation; top performance, which means providing the highest quality care to our patients; and care for the Commonwealth. When the Throughput and Capacity workstream was challenged to do this work, we knew that the first place we needed to start was by examining the quality of care that we were providing, as well as the efficiency of the care that we were providing. We knew this was the right thing to do, and we were glad that our senior leaders had listened to us and given us a roadmap. The next thing that we did was to develop a framework. So the framework that we identified to being critical to examine the efficiency and effectiveness of the care that we provide is seen here. We identified three critical components of our patient's hospital stay, beginning at the pre-admission point, moving throughout their hospitalization, and after discharge. We evaluated this along the continuum to assure that we were providing exceptional care to our patients. The focus of the presentation today, however, is in this during hospitalization phase. And you'll see that we divided that into two components as well: timely inpatient care delivery, and then ongoing and effective discharge planning, or transition of care. This was not a message of work harder, but instead, how can we leverage technology to communicate and coordinate care, to assure timely inpatient care delivery, and to drive ongoing and effective discharge planning. So we've talked about the roadmap that we used, which was given to us by our senior leaders based on feedback from those of us that work here. And we've talked about the framework that we used to examine the care we were already providing and what great care could look like. We then had to develop a structure and process that allowed us to accomplish this work. You'll see the structure before you has many key leaders, senior leaders identified, but more importantly, there are also a number of frontline team members who we knew had to be involved to tell us exactly what was working, but more importantly, what wasn't working. In the center of the slide, you'll see 3 starred boxes: communication vehicles, anticipated day of discharge, and interprofessional rounds. Those were the areas that the presentation that you're about to hear from my colleagues focused on. In just a moment, they're going to describe how we leverage technology across the entire interprofessional team to drive, anchor, and cement this work. Just so that you know, there were incredible outcomes from this work. Our length of stay decreased from 6.4 to 6.18. Our discharges by noon increased by more than 40%. Our ability to keep our doors open to the community at all times improved by more than 20%. So this was clearly work that made a difference and accomplished the mission that we said we wanted to accomplish. But I do have one final question before I turn it over to my colleagues. Why did we believe this work was so important? Because we were at capacity nearly every day. And so in business, when there's great demand for your service, you simply provide more of those services. But we couldn't. We could not open more beds. We also believed that simply opening more beds, even if we had them to open, was not the right thing. We had to improve our processes, because opening more beds without doing that would have only made a difficult situation worse, perpetuating the problem instead of solving it. So let me now turn this over to my colleagues to tell you how this work was accomplished.
Hi, this is Sharon Bednar. I'm a nurse at VCU Medical Center in Richmond, Virginia, and I am a performance improvement coordinator. I've worked with the throughput and capacity team through fiscal year 2018, and I'd like to share some of the work that we did to improve our patient outcomes and create an improved capacity and patient disposition processes. So VCU began our relationship with teletracking, which is our IT software platform for patient tracking and operations. In 2000, we built our bed tracking and transport tracking processes and mainly used teletracking for those 2 purposes. It wasn't until 2014 that we deployed electronic monitors to the nursing units and really began to change our culture from that of working off of grease boards to using the electronic teletracking boards for our patient and bed tracking. It was also that time that we began other fundamental work that would lay the foundation for the work in years to come. That included creating the patient portal. In 2016 through 2018, we implemented the care progression indicator, the DRG length of stay function, and the anticipated day of discharge function, which we'll speak to today. So our problem was that ineffective communication has the potential to have a negative impact on the number of patient days for our inpatients admitted to the acute care setting. We recognize that we have a very complex organization, and communication can be a challenge for among team members as well as across teams to progress the patient through the system in a safe manner. It can cause delays in care, and that's where we wanted to focus our work. The goal was to improve communication among and across teams and with our patients and families. We recognized as we pulled together a group of subject matter experts that we needed to have their engagement. We needed to focus on safety. We needed to create a process that reduced the use of paper, and we needed to make it meaningful to the team. We also needed to reduce phone call interruptions, as that was identified as a risk for patient safety. We also wanted to increase transparency so we could communicate with multiple people rather than just one, as a phone call does. And we needed to layer that communication so that we could progress the patient forward. Lessons learned throughout the process. We recognized that we really needed to change our culture. The culture at VCU has had decades upon decades of learned experiences, and we know that we recognized that we needed to change that culture if we were going to progress in a new direction. We also needed more effective education plans so that we could meet multiple different team members in the education level that they had and the focus that they had for each team that interacted with the patients throughout their stay. We needed clinicians' guidance so that we could create a tool that was meaningful to the care that they deliver, and we needed more interface support to accomplish those goals. So I'm going to continue to speak to you regarding care progression indicators. The care progression indicators really is a method for teams to communicate regarding the patient and the team's progress toward disposition or discharge. We recognize, as the slide shows, that there are multiple teams that interact with the patient throughout their stay, and we wanted to create a tool that would allow the teams to come out of their silos and understand where other teams were within the progress of progressing the patient toward disposition. The care progression indicator is a field in teletracking that is used as a communication tool. We started with a care coordination, occupational therapy, and physical therapy CPI, or care progression indicator. This was a platform in which the teams could update teletracking regarding the status of their plan for each individual patient. That way it remained individualized and special to the patient itself. Yellow meant that the patient was in progress and progressing. Green meant that there were no additional barriers and needs, and the patient was progressing as expected. And a red flag would show that the progress in the patient care was delayed for some reason. The care provider could then go in and see what that delay specifically was. The other icon I wanted to bring your attention to is the siren, which is a recommendation from one care team member to the other regarding something that is needed or suggested as a change. So as mentioned here, the care progression indicator would demonstrate the color of the progress as specific to that patient, and then the care provider could double-click on that window and gain additional information regarding what that delay or change in patient plan was. If further information is needed, the provider could always go to the electronic medical record where they could read the patient note or the provider note regarding the patient care. As soon as we began to implement these, it was soon after that we began to hear from other service lines that they were interested in having their own CPI or care progression indicator. Discharge Pharmacy was the first service line to reach out and request their own. We now have a waiting list for multiple service lines that would like to have their own care progression indicator, as they've all found value in this additional communication. So the Discharge Pharmacy CPI utilized a pill, and you can see as labeled 1 through 4 on the slide there. The green pill, the red pill meant that the nurse had sent the prescriptions for discharge to the pharmacy. This was a goal to be done the night before, sometimes the day of, but this way we knew that the prescriptions were written and sent to pharmacy to be filled. The yellow pill showed that the pharmacy had received the prescriptions and was actively filling the need. The green pill showed the prescription has been filled. A 4-digit code could be sent to release the medications from the tube system, but that would let the nurse know that the medications were ready to be picked up and that they were completed and ready to be given to the patient. In this situation, the alert icon, as shown on number 4, shows that there was a delay from the pharmacist perspective. This delay is most often a new copay that hasn't been addressed yet, or possibly a prior authorization that needs to be addressed before the prescriptions could be completed. So moving forward from the CPI, I wanted to speak to the diagnosis-related group length of stay, or DRG length of stay. This was a way, the DRG is a way to group and classify patients based on their diagnosis and comorbidities. At VCU Medical Center, we have clinical documentation nurses that generate the DRG, and they document the DRG based on the clinical documentation in the electronic medical record, and it is put into their software program, which is 3M360. We needed an interface between 3M360 and teletracking in order to have that DRG reflect in teletracking. This required a new level of interoperable functionality. It caused teams to challenge the status quo. So if we were looking at a patient with a certain diagnosis who is typically here for 8 days, but we see the DRG as 6.2, it allowed the team to question why. Why is the patient still here, and what can we do to move them along? Lots of times the patient's DRG needed to be updated due to clinical changes, but it allowed the team that information as a target so that we could begin those discussions. Okay, and I'm going to turn this over to Dr. McIntosh.
Hi, my name is Georgia McIntosh, and I'm a hospitalist and associate professor in the Division of Hospital Medicine. I want to talk with you about how our care teams transparently discuss and communicate about anticipated date of discharge for our patients. Before I tell you about our ADD work, I want to tell you about the journey that got us to where we are now. We initially had a very diverse way of handling discharge rounds across the health system. We spent a lot of pre-work understanding and optimizing those rounds and eventually created a uniform transitional care rounds for all units. Putting this into a structure helped us to do a number of things. As an academic institution, we first worked to separate the educational piece of rounds from the transitional care piece of rounds so that that time was seen as valuable to all team members. We also placed our care coordination team as the head of these transitional care rounds so that it would not be a physician-led discussion, but really a discussion led by our care coordination team. Once that structure was put into place, we then focused on embedding anticipated day of discharge into the conversation. We recognized early that talking about ADD was a satisfier from multiple aspects. Our providers noted improved satisfaction with increased and transparent communication across teams, and providers recognized there was an improved safety aspect as there were things that were being uncovered in TCR that previously only one person had access to. One thing that we did not anticipate but were pleasantly surprised about was the increased patient satisfaction as well. Our patients communicated to us that this transparent communication surrounding their transition out of the hospital was really a big satisfier for them. We also focused on not only discussing this with our patients but also communicating this on our patient communication boards. So how does ADD work? When patients are admitted to the hospital, for their first transitional care rounds after admission, the team discusses and enters the patient's ADD with the team's best estimation. The ADD becomes more meaningful as the inpatient stay progresses, and the ADD can then be updated based on additional clinical information. This can be used with the DRG, as Sharon mentioned before, but this should not be an absolute, but really a discussion point to help teams guide that conversation. There are two additional ways in which the ADD can be automated. There are two additional ways in which the ADD can be automatically updated. At midnight on the day the ADD is projected in teletracking, or when a discharge order is placed. Using this system helps communicate as a whole information across the health system. And with this information, we were able to increase our pending discharge communication. We recognized that, however, in order for this to be meaningful, the projected discharge date must be kept as accurate as possible. This is for the teams to discuss this on every transitional care round, and for our care coordination teams and leadership to enter this into teletracking. By using this system, we have been able to make significant improvements over the institution. From fiscal year 17 to 18, we have seen our discharges by noon increase by 19%, as seen by the blue bar. Our percent discharge compliance, which indicates when a discharge is pending to when they actually occur, has increased by 38%, and this is seen in the gray bar. This metric helps the organization identify bed capacity, and that can help us to reduce unnecessary diversion hours. We've also been able to increase our ability to anticipate discharges ahead of time, and that is also seen as a steady rise as indicated by that orange line, which is our pending discharge to duration average in hours. Our goal is to identify discharges up to 48 hours in advance, Currently, we're up to 20 hours, but with continued work on this important piece of information, we're hoping to anticipate our discharges ahead of time so that they will not be surprises. Now I'm going to introduce Cynthia Matthews, who is going to talk about the message from Medicare.
Good day. I'm Cynthia Matthews. I'm a nurse discharge planner in the Department of Care Coordination, and I'm the project lead on the updating of the important message from Medicare delivery process. It is one of our department's responsibilities to deliver the important message from Medicare, what we refer to as the IMM. The IMM is a regulatory document that is designed to inform patients of their rights to care during their inpatient stay. All Medicare patients meeting criteria are required to get an IMM. A key function of the IMM is to inform patients of their pending discharge. The IMM is intended to be delivered 1 to 2 days prior to discharge and no later than 4 hours. This time frame allows the patients to process their pending discharge and enact their right to appeal should they feel their medical needs have not been met. In our department, the Care Coordination Assistant, or CCA, deliver the IMMs based on the information from the discharge planners like myself. We've struggled with maintaining compliance and delivery within the intended time frame. A key issue has been the inability to effectively and efficiently communicate the need for the IMM and delivery with the intended time frame. Our most recent process change was the creation of the discharge pager. This pager is held by the Care Coordination Assistants. When a Medicare patient is discharged, a page is sent out to inform the CCA of the need to deliver the IMM. This process provided us with a safety net, but by nature nearly eliminates the ability to deliver the IMM with the intended time frame. Despite ongoing efforts to improve process, continuous compliance and delivery with the intended time frame remained a challenge until teletracking and the ADD workstream. In the end of last year, a small group from Care Coordination met with Kelly Berry, the teletracking administrator here at VCU, to update the IMM process with the use of teletracking. We rolled out our process change in 3 phases to accommodate the IT build and the ADD workstream. Phase 1 was about culture change. We wanted to get away from the Pavlovian response we created by the discharge pager. We re-educated and reframed the delivery of IMM process with our staff. We asked for delivery communications between the discharge planners and the CCAs to identify the Medicare patients and to anticipate discharges within 1 to 2 days. Phase 2 coincided with the ADD workstream going live. The discharge planners now place the anticipated day of discharge in teletracking. We also gain use of the teletracking IMM CPI column. Now the discharge planners entered the ADD and identified Medicare patients by manually entering a red M into the IMM column. The Care Coordination Assistant reviewed teletracking for the red M's and corresponding ADD. If the ADD was within 1 to 2 days, the assistant delivered the IMM, documented the delivery, and manually changed the red M to a green M. Phase 3 brought the full integration between IDX and teletracking platforms. IDX is the program used to register patients as well as document the delivery of the IMM, and this is how it works. When a Medicare beneficiary receives admission to our facility, it automatically populates the red M into the KPI column. And this is how it works. When a patient with Medicare is registered in IDX, it automatically populates a red M into the IMM CPI column in teletracking. Once that red M is in place, the Care Coordination Assistant monitors that patient, and once they identify a discharge within 1 to 2 days, they will deliver the IMM, and they will update in IDX that it was signed, and then the IDX interfaces with teletracking and turns that M to green, denoting that the patient has signed their IMM and they're ready to go. All right, and this is how it works. When a patient with Medicare gets admitted to the hospital, IDX registers them, and it sends a signal to teletracking, and it populates a red M into an IMM CPI column in teletracking. At this point, the care coordination assistant monitors the patients that have red M's and looks for the correlation between an anticipated day of discharge and ADD within 1 to 2 days. If they denote that, they'll deliver the IMM, they'll document it in IDX, and then IDX, again, feeds back into teletracking and turns the red M to green, signaling that the patient has received their IMM. If the patient exceeds their 2 days past their intended discharge, the M will automatically turn back to red, signaling the need for another IMM to be delivered. So this slide kind of shows our baseline data overlaid with our 3 phases of our updating of our process. The purple line and the red line that go across represent our baseline data. With our compliance, our baseline was about 75% compliant prior to process change, and our intent to deliver within 1 to 2 days of discharge was about 16%. On January 29th, we started without the technology and just the talking between our discharge planners and our care coordinations assistants, really focusing on identifying discharges 1 to 2 days out. With just that communication alone, we saw compliance go up to 81% and delivery of IMMs within 1 to 2 days go up to 43%. This slide is a snapshot of the data reflecting the process change. There are 2 lines. There's a purple line and a red line. That is our baseline data. The purple line represents our baseline of intent, delivery within 1 to 2 days, the intended time frame for the IMM, and the red line references our compliance. Prior to any process change, we were at about 75% compliant for delivery of the IMM, and about 16% of those IMMs were delivered within the 1 to 2 days. The 3 phases that we broke the process change down into started in January of this year, 2018, with just the conversation between the discharge planners and the CCAs talking about anticipated day of discharge. With that interaction alone, we saw an increase of 81% compliance and an astounding increase of 43% of delivery of IMMs within 1 to 2 days. The next phase was the manual entry in the use of technology with ADD and having a CPI column for IMM. We continue to see increase in compliance to 84%. We saw a slight decrease in the intended time frame of 1 to 2 days. In phase 3, we saw a 94% compliance rate and a 49% intent of delivery within 1 to 2 days. And we have consistently stayed there since the implementation of our new process changes. And now I turn it back over to Sharon Bednar.
Hi again, this is Sharon Bednar, Performance Improvement Coordinator. I wanted to speak to the return on investment and accomplishments that VCU realized through these projects. So with the use of the tools in teletracking, the return on investment utilizing teletracking for these projects realized a 20% reduction in lost bedtime, which equates to over 96,000 minutes. Lost bedtime is what we refer to when one patient is occupying 2 beds at one time. This happens when a patient has a ready bed, perhaps on another unit, but hasn't yet moved. In that time, the patient's occupying the bed they're currently in as well as the bed that they're assigned to and not yet arrived in. Those 96,000 minutes for those patients waiting for an empty bed are truly gold. This slide shows additional improvements that were realized through these projects, as well as a few others that worked in congruent with the throughput and capacity FY17 through 18 project initiatives. The inpatient length of stay improved. Our adult med-surg diversion hours improved. We were able to accept additional transfers and additional admissions by creating space and capacity through this work. Teams working together with improved communication to provide patient-centered care. That was the real return on investment. Looking back at the org chart in one of our first slides, those throughput and capacity initiatives combined helped to realize over $20 million in new revenue and savings to the institution. So our path to be a luminary site through teletracking has already begun by sharing our experiences with other organizations so they can learn from us. We started with end-user buy-in. We needed executive engagement. We couldn't have moved and changed our culture. We couldn't have moved forward and changed our culture without executive engagement. We utilized innovation and applied that to patient care settings. We integrated software programs so that we weren't asking for additional or double documentation, but rather better transparency and interoperability from the software programs already in use at VCU. We remain a data-driven organization, and by integrating these IT pathways, we were able to get meaningful data to drive our next project. And we are in the process of optimizing those programs now. We've been highlighted in Spheres Healthcare regarding our discharge pharmacy care progression indicator. We've also hosted site visits for UPMC, MedStar, and we've conducted multiple reference calls for organizations to understand how we are utilizing teletracking to support patient throughput and improve our capacity. Thank you.
Okay, and thank you to our speakers for joining us on this webinar today. And I'd like to remind listeners where to go find more Davies use case webinars and information on how to apply for Davies. You can find that information at the HIMSS Davies Award website at hims.org/Davies. That's hims.org/Davies.